Bismillahirrahmanirrahim. I'm Professor Iman Fouda, Head of Pediatric Pulmonology Unit at Ain Shams University. I am glad today to be a moderator of such an honorable session to present our experience in Pediatric Hospital Ain Shams University in dealing with COVID cases among the last 4 months, hoping to be beneficial for all doctors. Many thanks to all my colleagues, my professors in Pediatric Department at Ain Shams University for doing their best to offer optimum service to all our children with the leadership of Professor Mustafa Al-Hudhud, who managed this crisis excellently, with our manager, Professor Yasmin Gamal and Professor Jana Maher. Now, it gives me a great honor to present our role model and a perfect leader, Professor Mustafa Al-Hudhud, Head of Pediatric Department, Ain Shams University.
Shukran Jazilan. Thank you, Professor Iman. This is a very important activity in the hot topic of COVID and its sequelae. And I hope you are going to get the maximum benefit of today's activity. Thank you for the staff members of Ain Shams Pediatric Department who are role models in their activities and their initiatives and collaboration and team working. I will not mention one, otherwise I may forget a very important one. And I hope, Dr. Iman, we are going to get benefit as we said. So, Dr. Mona, can you give a summary of what's happening today?
Thank you, Dr. Mustafa. Before I start, I would like to thank the eminent scientist, Professor Mustafa Al-Hudhud, an example of a real leader during these difficult times in coronavirus. It was always a great pleasure to have Dr. Sana Abdulrahman with us. We will discuss our experience in Ain Shams University Pediatric Hospital regarding all aspects of COVID-19 virus affecting pediatric patients. The webinar will give answers. The webinar will give answers to the most important puzzles in which run in our mind. We will start by the eminent Professor Hanan Ibrahim, Head of Pediatric Department. Dear Dr. Hanan, would you please share slides with us?
Okay, thank you, Professor Ramona. Let us start sharing the screen. And to start with the first question. Okay. Okay. My first question is for Professor Yasmin Gamal, a professor of pediatric and the director of Pediatric Hospital Ain Shams University. From your position, Professor Yasmin Gamal, kindly inform us about pediatric hospital statistics and outcome of COVID-19 cases. Please, Dr. Yasmin.
Thank you, Professor Hanan. First, I would like to thank all our pediatric department headed by Professor Mustafa, our leader. I would like to also thank the Pediatric COVID Task Force for their continuous scientific, updated help and social, financial help. Thank you so much, being leaders and role models. Also, I would like to thank our head of university, Dr. Mahmoud Al-Mitani, Professor Ayman Saleh, our executive director, Professor Ashraf Omar, our dean, for their highly strategic management in this pandemic and letting us feel always secured and backed up in this pandemic. I will go through the impact of the COVID on our hospital. Please, Dr. Hanan, next. Okay, actually we are two big hospitals, around 180 beds, 32 NICU beds, 27 ICU, PICU beds, and 8 intermediate care, plus a lot of specialized clinics and outpatient services. Next. We are covering yearly around 50,000 ER visits and around 20,000 admissions per year. So this is the impact of COVID, as we can see in this graph, from around, the blue one is the ER visits, around 5,000 per month, to during the lockdown, decreased to around 1,700 visits, ER visits. Now we are around 1,008, we are increasing gradually, 1,800 visits. And all our ER patients are subjected to a pathway during the lockdown, pathway for the COVID patients, to segregate COVID positive patients and non-COVID, which will be discussed by Professor Iman Food. We can see also the admissions. We were trying to maintain our services throughout this lockdown, and our admissions decreased from 1,400 to around 500 cases per month. That means that we are trying to maintain our services as much as we can during the lockdown. Our specialized clinics, next, Dr. Hanan. Next slide, please. Our specialized clinics and outpatient services showed a huge impact, with around 25% only operating during this period. Now we are starting to open up our outpatient and specialized clinic starting from July. Next, please. During the month of May, we have also the impact on healthcare workers. We had around infection rates around 25% among our residents, and among our nursing staff around 40%. Luckily, we had no mortalities and no morbidities, and now all our staff are doing fine. Next. Also, we had impact on our resources. We had to reallocate our resources. 30% were allocated to the PPIs, personal protective PPEs, personal protective equipments. 20% allocated to the 6th floor, which is our isolation floor. 50% to our ventilators. And now we are reallocating all our resources to buying the management of multi-system inflammatory disorders. We are till now, which cost us till now around 850,000 pounds. Next. During the mid of May, we were overwhelmed with COVID cases that needed tertiary care, tertiary pediatric care, so we couldn't refer them, and we had to have our plan, which is doing the isolation floor or floor 6 in the new hospital, consisted of 20 beds, 8 ICU beds, and 12 ward beds, and the team were 2 lecturers, 2 assistant lecturers, 4 residents, 10 nurses, and every day is Zoom meeting with our professors. Next. During these 3 months, we had around 110 COVID positive cases in the isolation floor. During mid-June, we started having multi-system inflammatory disease, 22 of them. And the outcome of our COVID cases, 84% were cured, 6% were referred at the first, when we started the isolation floor, and mortality was around 10%. Out of the total multi-system inflammatory disease in children, out of the 40 cases, 22 cases were COVID positive. Next. These are our main clinical characteristics of our children in comparison to 3 major centers, China with huge epidemiological impact, China and USA and Italy. Our mean age was around 7 years old, and 80% of our patients had underlying comorbidities. So they needed the tertiary care, and they needed the ICU, the intensive care, the pediatric intensive care. Our numbers were more or less similar to the United States, and we are updating our registry every day. Next, Dr. Hanan. This is an analysis of our mortality. We had only 11 cases which were severe and the ICU admission. 4 of them died of COVID-related ARDS, 7 were non-COVID related, and the mortality was due to the main original disease. This sums up the statistics of our hospital. I thank again all our pediatric department for their continuous support and for their scientific impact on us and on our children. Thank you so much.
Thank you, Professor Yasmin. And since the early days of pandemic, the pediatric hospital was ready for this emergency situation. Our leader, Professor Mustafa Al-Hodid, assigned a committee of pediatric professors from the concerned subspecialties to actively and effectively write a protocol for COVID-19 cases management. Our pediatric protocol was established and distributed to all our residents and staff to deal with any suspected or confirmed case presenting to the ER. Professor Iman Fouda, could you tell us about our protocol?
Thank you, Professor Hanan. Actually, with the help of great professors in pediatric department at Ain Shams University, we started to do our own protocol. Actually, the main aim of this protocol is to deal with any child coming to our emergency room pediatric hospital with fever. Among the fear of parents, among the fear of children, we should deal with those cases coming to our ER and to answer a very simple question in the beginning. Is this case is a possible COVID-19 or this is non-COVID-19? Next. So when you got a child with fever in the emergency room, we need to categorize the patient if it's possible COVID-19 or no. First, we are depending upon epidemiological character. If this patient has contact with a case suspected or confirmed COVID-19 among the last 2 weeks, or contact with any case of fever with or without respiratory manifestations. Again, if the patient has fever and have respiratory manifestations in the form of cough, whether dry or productive, dyspnea, grunting, or just chest pain. GIT manifestation was one of the presenting features in the emergency room in patient with fever. So we asked about vomiting, diarrhea, unexplained abdominal pain, loss of taste. And other also clinical features we searched about, which is Kawasaki-like illness, which we are going to discuss in details later. Some neurological manifestations such as convulsions or impaired level of consciousness. Actually, we encountered some cases with this presentation. Unexplained tachycardia or anosmia. If the patient with fever has any of these criteria, we label this patient as suspected case of COVID-19. However, if the patient has an obvious cause of fever, such as acute follicular tonsillitis, otitis media, urinary tract infection, and have no history of contact, we are going to manage him according to the case, and we are going to label him as non-COVID-19 case. Next, please. Okay, so if you got suspected case of COVID-19, depending upon the previously mentioned criteria, we are going to start to do some lab investigations, including CBC, CRP, and chest X-ray and CT if the patient have respiratory manifestations. If the patient have no lymphopenia, normal CRP, and normal chest X-ray, we are going to reassure the parents, discharging home, asking them for isolation for observation, maintaining good hydration of the patient, and also advising good nutrition and enough sleep. And we are going to inform the patient about any warning signs. Let them come back to our emergency room. For example, dyspnea, grunting, impaired level of consciousness, gastrointestinal manifestations. But if the child, which is labeled suspected case of COVID-19, have leukopenia and lymphopenia, high CRP, or abnormal chest X-ray, we are going to request nasopharyngeal PCR. And at this stage, we are going to stratify our patients according to severity to decide this patient is going home or being to be admitted in the ward, admitted in isolation, admitted in suspect room, or admission in pediatric ICU. Next, please. So if the patient is PCR positive, but he has mild symptomatic cases, it means he has leukopenia, lymphopenia, but he has no clinical or radiological evidence of respiratory affection, we are going to release this patient home with careful advice about all measures of isolation. and we are going to give antibiotics according to the weight of the child, maintaining good hydration again and good nutrition, giving some vitamin supplementation such as vitamin C, zinc, and vitamin D, and all can be written to the patient in the proper dose to avoid overdose and vitamin toxicity. In addition to the lactoferrin, and again, the patient being informed about the warning signs of deterioration, which is let him come back to our emergency room. Next. If the patient is PCR positive and this patient had been will be classified as moderate disease, this means if the patient have some respiratory manifestations, respiratory distress with finding in the chest X-ray or CT showing pneumonia. However, he is not hypoxic, means that oxygen requirement is okay. It's over 90% on room air and is hemodynamically stable and no signs of other organ failure. We are going to admit him in the 6th floor for isolation, and we are going to start a supportive treatment, including IV fluids, vitamins in mild cases, and sometimes we are adding lactoferrin. In addition to the usual protocol, which is according to the national and international guidelines, we are giving azithromycin in 10 milligram per kg once on day 1, with maximum 500 milligram per dose, followed by 5 days with the same dose of azithromycin 5 milligram per kg. If we are suspecting secondary bacterial infection, we are giving to give ceftriaxone 100 milligram per kg per day, once per day for maximum 5 days. Actually, steroids had been added to the protocols of COVID-19, and so we are adding dexamethasone 150 microgram per kilogram as base once daily, with our maximum daily dose 6 milligram for 5 to 10 days IM or oral, and actually it helped the patient in passing the critical stage of respiratory affection, or giving alternatives of prednisolone and methylprednisolone. And the cornerstone nowadays in management COVID-19 cases is the anticoagulation. We are giving the prophylactic dose if the D dimer is above double in normal, it means above 1,000, and the dose below 2 months is 0.75 milligram per kg subcutaneous every 12 hours till the D dimer becomes normal, and above 2 months we are giving 0.5 milligram per kg subcutaneous for every 12 hours. Next, please. If the patient is starting to show the severe manifestations, it means tachypnea, which we all know the rate of tachypnea according to the age, and the patient is starting to become hypoxic, it means that oxygen is less than 90% on room air. However, he is still hemodynamically stable and no signs of organ failure, he is not in need of the assisted ventilation, he is labeled severe case of COVID. And this is the X-ray of some of our cases. While the patient, if he start to be a critically ill one with oxygen saturation less than 92%, in spite of giving more and more oxygen therapy to maximum 6 liters per minute, or if the patient has septic shock or become hemodynamically unstable in spite of the fluid resuscitation, or if the respiratory manifestation continue to be present in addition to other organ failure, in this stage, the patient will need mechanical ventilation, and we are going to refer to BQ for isolation, and we are going to hear the protocol from my dear Professor Hanan Ibrahim. Next, please. So what are the indications of nasopharyngeal swab? We are doing nasopharyngeal swab for PCR for all hospitalized patients with symptoms, especially if they are immune compromised. In any symptomatic infant below 1 year, being the mortality high in this vulnerable age group. Healthcare worker with symptoms, new onset of symptoms in those already admitted for any reason, then started to have symptoms related to COVID. Symptomatic oncology outpatient in emergency department who are going to be discharged at home, and of course, those oncology patients who are going to be given chemotherapy, we should be sure about their PCR results before starting their chemotherapy. Also, the neonates with COVID-19 positive mother 1 or 2 days after delivery. Next, please. We are going to discharge the cases back home if his body temperature is normal for more than 3 days without antibiotics, if the respiratory manifestations improve, if the chest X-ray or CT becomes better, if they have no comorbidities and no complication, which requires more and more hospitalization, if his saturation of oxygen on room air is above 94%, and the decision to discharge the patient is only taken by the multidisciplinary medical team who are caring about these positive cases. Next, please. This protocol actually was weekly updated, guided by the national and international protocols. And after being updated, distributed with full explanation of all the new changes to our resident and staff. Follow-up of all our cases will be done on daily basis to record any difficulty or any atypical presentation, especially children with comorbid condition. Actually, we have a lot of comorbid conditions with COVID-19 among the last 2 months. Actually, I want to thank the COVID-19 program committee. These are all my friends, my dear professors who helped me a lot during putting the protocol and updating it. Also, I want to thank the frontline doctors, our residents, our heroes who faced this tragedy actually. Without the help of the COVID-19 program committee, without the help of our heroes, residents, we couldn't reach success in controlling such pandemic. Thank you.
Thank you, Professor Iman. In spite of the initial concept, that COVID is a respiratory problem, we noticed a lot of cases that presented with GIT manifestations. Professor Mustafa, would you please shed some light upon the GIT manifestations of COVID-19? Dr. Mustafa?
Unmute me? Yes, I'm unmuted. Thank you, Dr. Hanan and Dr. Iman. And I will make it short regarding the GI involvement in COVID-19. I will tell you that pediatric disease started something like 3 months after starting in adults. Again, a few weeks ago, it started to be predominantly gastrointestinal presentation than respiratory presentation. Next. In Shams Children's Hospital, when there were 104 cases who were diagnosed with COVID-19, 26 had presentation with GI disease. However, in other patients starting with respiratory, they may have as well gastrointestinal manifestations. But here I'm concerned with those who started with GI presentation, including diarrhea, vomiting, bleeding, or any combination of all these, as we are going to see. The overall frequency of 25%, most of them were seen in the last 2 weeks compared to the first 1.5 months of presentation. This is significantly higher than those presented all over the world, especially that by Liu in New England Journal of Medicine, June 2020, in which they reported almost about 10% presentation. Next. Among 32 COVID-19 children I have seen, whether they came to me and the primary diagnosed with me or assessed after recovery, I have seen the following. Next. You can see here the presentations, and in red, this is the early presentation in the first few hours of the disease, and in blue, this represents the presentation later after an average of 10 days from the start of the disease. And you can see here that diarrhea, vomiting, or both occurring together, and abdominal pain can start in the very early beginning or be a late manifestation as well. However, hematemesis, melena, and the bleeding per rectum were not seen in the early presentation, and they are among the hallmarks occurring as an evidence of GI involvement late in disease. Next, please. GI disorders is getting more common than respiratory in last few weeks. GI bleeding is a feature of late onset affection. The features predicting COVID-19 in patients with early symptoms are, these are my observation. Vomiting is surgical, is like what's happening in a surgical condition, and it is usually prolonged even after resolution of other symptoms, severe with inadequate response to medications and stopping all oral intake. Abdominal pain is both severe to suggest a surgical condition. Both vomiting and abdominal pain usually ask the surgical opinion because of their severity. However, they are not surgical. And the abdominal pain is usually prolonged, taking about 3 weeks after resolution of all other symptoms of the gastrointestinal tract. And the data collected from the GI perspective is greatly different and having many observations that were not reported by the published international array of works, and we are preparing to publish these data accumulating. Thank you.
Thank you, Professor Mustafa. And now we will shift to the Miss C. In late May, our pediatric hospital, Ain Shams University, reported the first case of Miss C, multi-system inflammatory syndrome in children. This case was followed by many other cases of Miss C related to SARS-CoV-19, and a lot of them were in a critical condition and in need of emergency intervention and PICU admission. Professor Ilham Hosni, would you define Miss C and illustrate the immunologic background of Miss C? Professor Ilham?
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Hanan. And allow me to introduce some data about the immune storm that happens in cases of the multi-system inflammatory syndrome in children, or the MIS-C. May I have my first slide, please? Okay, concerning the definition of MIS-C, we have two main definitions, that of the WHO and that of the Centers of Disease Control and Prevention, Atlanta, Georgia, the CDC. Basically, both are the same, but the WHO started by defining it as cases between 0 and 19 years of a fever of more than 3 days and 2 of following: rash or bilateral non-purulent conjunctivitis or mucocutaneous signs, hypotension or shock, myocardial or other cardiac dysfunction, evidence of coagulopathy, acute gastrointestinal problems. Together, elevated markers of infection, evidence of or contact with a proven case of COVID-19 with no other explanation or microbial cause. The CDC broadened a little bit. It made it up to the age of 20 because they had in the US cases of 20 years old individuals with MIS-C. So they said any individual less than 21 years of age with a minimum of 20 hours of fever, at least 8 degrees centigrade, and severe illness to the extent that it requires hospitalization, plus 2 or more organ system affected. And again, they said there's laboratory evidence of inflammation, at least one biomarker, laboratory or epidemiologic evidence of exposure to SARS-CoV-2 infection, and no other alternative diagnosis. Next, please. The control is not working. Dr. Hanan, could you give me my next, please?
I also cannot control the slide. Would you try again, Professor Ilham? Because the control with you.
It's not working, unfortunately.
Not working. Let me.
Okay, I will give up.
I will abort the control. I will abort the control. Okay.
Okay. Then give me the next.
Okay, 1 minute. There is something wrong. Okay. This is the next one.
Okay. This is an infograph showing the CDC criteria for the diagnosis of the MIS-C. As you can see from on your left-hand side, there should be a lab evidence of COVID-19 currently or past infection in the form of antibody response, or a clear degree of contact with a positive case of COVID-19. And then the patient will come with the fever and myalgia, is a constant finding, together with constitutional manifestations in the eye, rash, lymphadenopathy, stomatitis, extremity swelling. All these look like Kawasaki, and from here came the name Kawasaki-like. But we should be two more major organ affection: the heart, the GI, as Professor Mustafa Hudhud outlined. There could be coagulopathy, thrombocytopenia, failure or hyponatremia, pulmonary affection, although it is not very common in these cases. In the same time, or to your right-hand side, there should be at least one biomarker of inflammation that is positive. Next slide, please. Demographically, from the largest cluster presented to the CDC, they said that males outnumbered females in terms of MIS-C, and that the age of predilection was between 1 and 14, with a median age of 8.9 years, unlike the Kawasaki, which happens much earlier. Next slide, please. Why would develop disease, including MIS-C, or and not have it mild, as most of the cases of COVID-19 in children, which are mild? As you know, basically, the immune response of a person is divided into two immune systems: the innate immune response and the adaptive immune response. In any viral infection, the innate immune response works first to try to decrease the viral load and present the patient to the adaptive immune system in a favorable way, so that the adaptive immune system can do its without going crazy, without exaggerating its response and producing a lot of chemokines. So at first, the interferon response happens. The interferon response, usually in a normal person, is very high and occurs promptly, rapidly, in a short time, and this helps in decreasing the viral load, which is shown in the light blue. If this happens, an early interferon response, a rapid clearance, then the inflammation will be less. There will be less level of cytokines such as interleukin-6 and chemokines. For the adaptive immune system will work reasonably. The previous slide, please. The adaptive immune system will work in a favorable way, producing IgG antibodies, and this will be a mild disease. On the other hand, if the viral load is high, such as what we see with the healthcare workers that lost lives due to a high viral load, or due to genetic predisposition, or to the assumption that the SARS-CoV can attack the interferon response, in that case, the interferon response will be delayed. It will take a longer time to happen, and the viral load will take a longer time to decrease in amount. Therefore, the adaptive immune system will start working purely while the innate response didn't do its job yet. That's why it grows crazy. It produces a lot of cytokines, more inflammation, leading to severe disease, including the MIS-C. Next slide. This slide shows it all. If you look to the upper part of the figure, which is marked by the letter A, you will find first to your left-hand side that the virus inoculation happened in no time, about 5 days incubation period, and then a normal antiviral response occurs. The upper part of the figure shows the healthy immune system, the normal response to the virus. What happens? The innate immune system works first, producing interferons, type 1 and type three interferons, alpha, beta, and lambda, together with interleukin-1, which leads to fever, the pyroptosis, and the cells will work in the form of cytotoxic cells, natural killer cells. They will work very well to get rid of the largest amount of the virus before the adaptive immune system has to work. Of course, the macrophages will present the virus to the T cells. And here we will have the inflammatory M1 macrophages. This will result in inflammation as well, but in a reasonable amount of inflammation, with interleukin-6 and interferon gamma producing inflammation. The next step, right with me, to the addition or the getting rid of the virus. This will happen through the cytotoxic T cells, the B cells, and also the T regulatory cells will work to ameliorate the amount of inflammation. And control on the disease will happen through neutralizing antibodies of the IgG type, opsonization, phagocytosis of the virus by the macrophages, and the T cytotoxic cells as well. And the T regulatory cells, and the regulatory macrophages will ameliorate the infection, leading to recovery and action of immunologic memory. As you can see in the figure, the virus is contained with the IgG antibodies around, decreasing its inflammatory effect, and these antibodies are going to cause immunologic memory. The lower part of the figure, on the contrary, shows the unfavorable response. It starts again with inoculation by the virus, and there's an abnormal immune response. The interferon delay, decrease in the interferon, the natural killer cells are not doing their job, and the T cytotoxic cells not engulf the virus enough. The result will be high level within 5 to 7 days of interleukin-6, tumor necrosis factor alpha, and many chemokines, and the Treg cells will not have time to do its job in ameliorating the inflammation will be horrible. Go to the right, you will find inflammation is horrible, leading to endothelial damage and alveolar damage. The endothelial damage is not going to affect the lung as the natural COVID-19 only, but also the brain, the eyes, the skin, the heart, the kidneys, the gut, and the liver. The outcome will be either recovery if the individual is lucky, or death. The death is due to cytokine storm or the coagulopathy. So why would the immune response be normal? What happens actually in patients with deranged immune response, such as those with preliminary inflammatory response, such as cases of rheumatologic diseases, for instance, and it seems that pediatric rheumatologic illness is a risk factor of misty and severe COVID-19 manifestations. Also, if the viral load, or there is that says that the SARS-CoV-2 is able to abolish the interferon response. In that case, we will take the worst scenario, which is severe MISC and death of the child, unfortunately. Next slide, please. This is my last slide. It shows the laboratory markers in patients with MIS-C from the largest cluster of cases of MIS-C that were published in England Journal of Medicine last month. It was a cluster of 186 children with MIS-C. It shows lymphocytopenia is the most common, of course, together with neutrophilia. Combination of lymphocytopenia with neutrophilia. Hemoglobin less than 9 grams per deciliter, thrombocytopenia, and a D-dimer, which is above 3,000 nanogram per milliliter. Fibrinogen will be high. And this is, on the contrary, classic cases of activation syndrome in which we find the fibrinogen consumed, but in the fibrinogen is elevated. The INR is elevated. The INR is elevated. That is decreased. C-reactive protein elevated. Ferritin above 500 nanogram per milliliter. And the ESR is again elevated. Although in most cases of macrophage activation cytokine storm, you find it decreased, but in MIS-C it will be elevated. And of course, the biomarkers and the enzymes. I wish that I could deliver the message of the immunologic background of the MIS-C, which is the main pathogenetic pathway. And thank you very much indeed for attention.
Thank you, Professor Ilham. And now I will leave the screen share to my dear colleague, Professor Iman Foud.
We are honored today with the presence of Professor Mahmoud Al-Mitini, the president of Ain Shams University, and he is our backbone, and he is the backbone of our Faculty of Medicine during this exceptional era of COVID-19 pandemic. I would like to thank him for his unlimited support to Pediatric Hospital. Dr. Mahmoud, please.
Thank you very much, everybody. And I don't know if you can see me and you can hear me now.
Yes.
Okay. I'm sorry, first of all, to be late. I just finished my everyday work in the office. As you know, things are very hectic these days. And I really enjoyed the second half of Professor Ilham Hosni. Wonderful presentation. I really learned from her a lot, as usual. And I would like to thank Professor Mustafa Hudhud and all the pediatric team and the great job you did during the COVID-19 since the very beginning. Actually, your numbers were not as high as adults at the beginning, and we thought that you would be blessed by not having cases at all. But you guys, now you're working. I think you're having a lot of cases now. I'm sure that we'll through the panelists, the great names I've just been through, all of you will present extremely good experience, and I would like to share with you. I'll try to stay as long as possible to share with you your thoughts and reflection about this very new disease that really hit the whole planet very hard. Didn't leave a country without hitting it. I think we in Egypt, nothing is perfect, but we did a good job, or did at least a fair job, over the last 4 to 5 months at a national level. Coming to Ain Shams University, I think we all, with your help and Professor Ashraf Omar, I believe is with us now, if he's still there, and the Faculty of Medicine, Ain Shams University, as usual, were up to the challenge. We had the first quarantine hospital. I don't like the word isolation. The quarantine hospital at the first university-based quarantine hospital in Abur, and this was followed by another 4 sites, the last of which is the first field hospital, as you all know. We just started 1.5 months ago, and the plan is to keep it actually together with the Abur hospital until maybe January or February, until we see what will happen over the coming autumn and winter, if God forbid have another spike or so. Speak about the current situation. I think we should be all proud that in Ain Shams University we served more than 7,000 patients. 4,000 plus were from these 7,000 plus patients. We served them by home isolation and telemedicine, and they were guided by our frontliners, really our heroes from the chest department, ICU department, anesthesia and ICU actually, the tropical medicine, and what as a preferred name now, infectious disease, that I would love them to change their name. The time has come for that. I asked this 3 years ago, but nobody listened by that time. I think now the time has come for that. And the family medicine department, which really astonished us and surprised us by the quality of work they did, managing the triage in the Demirdash and I would like actually to praise them, these 4 departments, as much as I'm doing now for the pediatric department. And the internal medicine department as well, with Professor Maged Rifat, I think played a big role for that. So everybody actually, except the surgeons maybe, we were on the back, but we were ready to assist whenever possible. And I think in the Merdash Surgical Hospital, we opened recently one of the quarantine hospitals there, and again the guys there did a great job. So everybody, all physicians and professors and medical workers in Ain Shams University, nurses, the administrative body, everybody really were up to the standard and up to the challenge, and we all carried the brand together. And all this, we did this, I said, more than 7,000 patients being served by Ain Shams Faculty of Medicine and Ain Shams Hospital, 4,000 plus at home, 3,000 plus in different sites of the 5 sites I just mentioned, with wonderful results, up to 84-85% recovery at least. And all this has been done for free. All hospitals around us, whether university or private, as you heard, or wherever, at least part of the service has been paid. And I've been asked to do that, whether internally or externally, even from higher authorities. But I insisted that within a pandemic, it's our role and our duty as physicians and as healthcare workers together to find every way possible to keep it for free, regardless social level, regardless the kind of patient. And I think we succeeded in this. So without you and without your commitment, we couldn't have done that. So thank you all, and I wish you a very happy webinar. And you know that I'm always biased to the pediatric department because of the quality of work you present. The 4 years I stayed as a dean with you, you really astonished me day after day, and that's why we did together the new pediatric hospital. And now I'm promising to finish before I leave the refurbishment of the old pediatric hospital, and I hope that I start at least the 3rd hospital for you, which will be the pediatric surgery hospital attached to the two, to make a really pediatric campus within the big campus. And there are some good news, thanks to the higher authorities and their support, that now very soon we will have the whole campus from the cathedral to Al Noor Mosque and from Lotfi Sayyid to Ramses Street. We'll have all this encompassed and dedicated for our beloved faculty of medicine and Ain Shams hard with the government of Cairo for that. And I think you will be the people who will, at least our youngsters, I've only got only 2 years more to go, but our young staff are doing all this for our young staff. Our hope that they will take good care of us, I'm sure, in the near future. Thank you all, and I'm sorry if I've been long, and I'm sorry again for being late, and I'll leave the floor for you. Thank you.
Thank you, Professor Mahmoud Al-Mitini. We are honored actually by your attendance with us today and your continuous support to our pediatric department. I would like to extend my gratitude to Professor Ashraf Omar, the Dean of the Faculty of Medicine at Ain Shams University, for his sincere support of pediatric department with rapid response to all our needed requirements to face this pandemic. Professor Ashraf, welcome.
I really appreciate the efforts of all of you. All the members of the pediatric department have done a great job. Your efforts are really appreciated from the administration. I think COVID disease was a very challenging disease for all of us. But I think not only the staff was to the point, but also the young generation have done a great job. You are always doing a very, not only for treatment, you are also a very high standard of education. I think the distant learning is now a mandatory point, not only as before in the pre-COVID area. The blended learning is very important. I'm following with the students also how the blended learning is going on. And we have done an exam in this, the general surgery. I think Dr. Mustafa also is preparing for the round to be done in the faculty by getting the patients in the faculty. And we have arranged with each other how to maximize the benefit of all of the infrastructure of the faculty so as to maximize the benefit for the students. Thank you very much for all of you. And we are ready to help and to support any of your needs. Thank you.
Thank you, Professor Ashraf Omar. And back to our scientific program. While the lung was the primary affected organ in COVID-19, MESI seems to attack mainly the heart. Professor Alia Qutbi, please tell us more details about the cardiac affection of MESI cases.
Thank you, Professor Iman. Before starting, I would like to thank Professor Mahmoud Al-Mitaini for honoring us and being with us, and Professor Ashraf Omar. Professor Al-Mitaini, I was very proud because you were always taking a few steps ahead of problems and matters. First, by opening an award in a very good time and saving many lives. Thank you for that, because it was always a relief for us to feel that we have a backup. We have our bags covered. So thank you very much. At the same time, you took a further positive step of opening the quarantine hospital, the new one, the large one, and thank you very much. These are good. You're always taking a positive step in the right time and ahead of time, and thank you for that very much. Thank you for the support to the pediatric department, and I think we really need more support nowadays because of the things we're going through, and I'm really grateful to all those working at Ain Shams University, all the departments you've mentioned, because they saved lives, our lives, and a lot of lives. And I would also like to thank our heroes in the pediatric department, the young doctors. Thank you very much. Professor Ashraf Omar, I thank you very much for your support to the pediatric department. He's always with us, attending our meetings, and we're giving him such a difficult time because sometimes we have more than one meeting at the same time. We are very active in that and in our scientific activities and in our exams. So thank you very much, everybody. So I'm going to start. Can I have the next slide, please? Thank you. If you look at this slide, this shows what occurs after infection with the SARS-CoV. The first few weeks, we find that the patient can develop the COVID-19. At first, everybody thought that the COVID-19 in children, because it is mild, they don't have mild symptoms. We're not going to be seeing any of them, but then we started seeing them, and we were surprised when we saw them in the pediatric department that they had cardiac symptoms. And the cardiac symptoms were always obscured by the chest symptoms, because the patient would have respiratory distress, he's having chest pain. Everybody thought was that due to a respiratory or due to the lung problem. And then at the same time, as time went by, and by the time the weeks went on, the MIS-C started to appear. And as Professor Ilham has described the MIS-C, with the appearance of the late response about 3.5 weeks, 6 weeks after the peak of the COVID, the MIS-C appeared. It appeared, we saw the first case in our hospital by late May. And I remember in early June, I said we're going to see our peak of the MIS-C by the middle or to end of June. And this is what actually happened. We were seeing many cases of MIS-C. Both of them had cardiac findings. But if we say in adults, the adults had 20% having cardiac findings during the COVID, but in the MIS-C, most of them, 70% or more, will be having cardiac findings. So we have to look at the patient, look at the other manifestations. If you see a patient nowadays, you first have to decide, is this a COVID, the early stage, the classic COVID, or you're talking about a MIS-C? Next slide, please. The MIS-C was first described because it has got some features with Kawasaki disease. And Kawasaki disease, as you know, they have the fever for a few days, the red eyes, the rash, the lymph nodes, the mouth findings, the edema of the hands and feet, rash all over the body, and the thrombocytosis, and they have the cardiac manifestations. So they started to say, is this a Kawasaki disease? Or is this COVID causing something like a Kawasaki disease? But they found differences between both, and they started to compare. They found that in the MIS-C, the mean age was between 6 to 10 years, and they found that the mean was about 8 years. In the Kawasaki disease, it was less than 5 years. But then again, if you find an adolescent with a Kawasaki disease, it might also be Kawasaki, but you have to look clearly at the other symptoms. As regards ethnicity, the MIS-C was found more in Afro-Caribbeans, and maybe in some of races, maybe we are more prone. We have to look at that. And the Kawasaki disease was found to be more in Asians. The gastrointestinal symptoms are prominent in the MIS-C. They present with it, they come up, they may even present with gastrointestinal bleeding, as was Professor Hodhout has mentioned before. But in the typical Kawasaki, no, it was less significant, maybe not important or that much. Okay, maybe sporadic cases, but then again, it is not a prominent feature. Inflammatory markers in the MIS-C are markedly raised, okay, but they are raised also in Kawasaki disease, but not as in the inflammatory markers in the MIS-C. Now, in the MIS-C, we have heard first of the CRP. In Egypt, it is more than 6, which is considered positive. With the COVID, we have seen it to be rising 120, 130, numbers we never heard of. But then again, in the MIS-C, we were hearing about 230, 250, and things we never dreamt of hearing of as regards the numbers and the very marked rise of the inflammatory markers like the D-dimer, the interleukin-6, the ferritin, and all of those who really, and the LDH that rise. Moreover, the marked rise in the troponin, cardiac troponin, and in the BNP. Another difference is the presence of thrombocytopenia in the MIS-C versus the thrombocytosis, which is present in the Kawasaki disease. If you find the Kawasaki disease years before, we found the thrombocytopenia in a Kawasaki, we said this is the very bad prognosis. Okay, most of the patients with the MIS-C have thrombocytopenia. Next slide, please. I tried to gather the findings of the cardiac manifestations of the COVID and the MIS-C. Now let's imagine the systemic hypertension and shock. They are present in COVID-19, but not that much. If you look at the MIS-C, 75% of the patients present with shock, and this is alarming. The patient comes to you to the ER in a shock stage. So it mainly affects the heart, circulatory or other forms of shock, but the circulatory component is marked in it. In the Kawasaki disease, in some studies, it is only 3%. So you can see that most of the cases of MIS-C really have this shock. It's very important to be aware and prepared to act for managing this case in the ER and then in the pediatric ICU. The mitral regurg and the tricuspid regurg. This is very important to talk about because during the first cases of the COVID-19 cases, when they were telling me we were seeing the valve affected, at first I said, are you sure the valve is affected? They said, yes, the valves are thickened. And I told them again, are you sure? Because the valves are thickened. In literature, في العلم عندنا, this is rheumatic fever, this is collagen disease. If it is not congenital, myxomatous, And this would be really something new, but we were then finding that it's really present. And we found in literature that transient valvulitis was really mentioned, but in other studies. In the MIS-C, it is markedly present. The valves are really affected. They are thickened with transient valvulitis. In the Kawasaki disease, it was mentioned, but it was not that of that importance. And actually, we saw it quite rarely. The myocarditis is present a lot with decrease in the ejection fraction. And because everybody cares about the myocarditis, it's very important. It can also be present during the acute COVID-19, but it is more present in the MIS-C. Sometimes the patient might be having left ventricular dilatation and even with decreased ejection fraction. Or sometimes the ejection fraction is borderline and there is mitral regurgent, tricuspid regurg. What about the coronaries? The main problem of Kawasaki disease is that it causes coronary aneurysms, and this was the fear from the MIS-C. We found dilated coronaries in the MIS-C. We didn't find these findings, the dilated, in the COVID-19, in the early cases of the COVID, but we found it in the MIS-C. So what about the echo-bright coronaries? Sometimes they talk about it as prominent coronaries and they ask them, are they dilated or not? They say, no, they're not dilated. But if you look in the papers, actually it is written the echo-bright coronaries. What are echo-bright coronaries? Why do they write echo-bright coronaries? Because coronaries are not easily found. You have to look for them to find them. But in doctors who are just training to look for the coronaries, they get the view of the coronaries, and they look at the coronaries, they find them quite easily because they are bright. Why are they bright? Because there is inflammation of the endothelium of the coronaries, and this indicates that they are also affected. But aneurysms, which is the hallmark of the Kawasaki disease, is not quite, we haven't seen it actually in our cases. Maybe we need more time, but in some studies, they said it is present up to 15%. And if you look at the different studies, you have to understand that in different studies, there are different findings. The pericarditis and pericardial effusion, the pericardial effusion, it was very common in the early cases of COVID-19 with massive effusion, at sometimes moderate, but mild, but maybe it's also in all cases. Nowadays, it is seen, but it's a mild effusion. In Kawasaki disease, it's also rare. Myocardial infarction mentioned only in Kawasaki disease. The right ventricle and pulmonary hypertension were very common in COVID-19, mentioned in more studies than other studies. Now, we cannot say they are absent. They are actually, some say they're absent. We are not saying no. I think they might be present in some cases. And there is something just I want to add. We have to understand that we are talking about an evolving disease. We don't have idea what the COVID-19 and the MIS-C disease causes. We don't know. We are learning. We are learning from the patients. And now we can see that it is causing the valves to be affected. I think the whole spectrum of the disease hasn't been fully described up till now. It is an evolving disease that we really have to follow later on. The different ECG abnormalities are found all through the time in these diseases. Next time, please. In order of frequency in the Kawasaki's, we found the aneurysms, the myocarditis, followed by the pericarditis, systemic arterial aneurysm in the rest of the body, valves, and mild aortic root and myocardial infarction. But in the MIS-C, the hypotension and the shock were the main, and we are afraid of them. Then the myocarditis and decreased ejection fraction, the valvular diseases that I talked about, the coronary involvement and pericarditis. And up till now, we are not able to say that there are systemic arterial aneurysms. We haven't seen other infarcts. Next, please. There are some clinical pearls about this COVID and the cardiac affection. Circulatory collapse can be the presenting symptom or occurs late. If you look at the criteria of the CDC, they said 24 hours. The WHO said 3 days. And when I read the 24 hours, I said at first because I didn't see that in early May, and we didn't have cases of MIS-C. I said 24 hours. This is so short. What is a fever of 24 hours? What's that important? And I was alarmed when we saw the patients because they did not take more than 24 hours to enter in shock. Patients deteriorate very rapidly. And sometimes the patients come to you, he's okay, and he has the findings, red eyes and the rash, and he has got high troponin and the heart is affected. And all of a sudden, after being well for say 24 hours, he enters into hypotension and shock. Comorbidities are very important precipitating factors, particularly the rheumatic diseases, as Professor Ilham mentioned. Also the diabetics. I found that it precipitates the occurrence of new diabetes and new attacks of ketoacidosis that are very difficult to control. And those who are working with diabetic patients know a very difficult to control patient will turn out to be COVID positive patient. Fortunately, up till now, the thromboembolic events are not observed in the MIS-C in spite of the increased D-dimer. We have increased D-dimers up to 3 because this is the levels we measure with. It's not raised. Follow the cardiac status should be done with the troponin, the BNP, the CRP, ferritin, and the rest of the markers with the ECG and echo until the patient improves. The supportive intensive care and inflammatory therapy leads to clinical improvement in most cases, and this is good. If you use the IVIG and the anti-inflammatory, it is really good. And moreover, most of the patients, the cardiac findings, they improve within a week to 10 days. Next slide, please. But still, we have some questions to be answered. We have to see whether we have genetic predisposition to the MIS-C, and the long-term sequelae has to be followed up because we don't know whether these findings the valve affection will have long-term sequelae or not. It's true, it disappears quite early, but then again, the coronaries and so on have to be followed for weeks. And the MIS-C syndrome, is it a Kawasaki disease caused by SARS or a disease by itself? These are questions that need to be answered. Thank you.
Thank you, Professor Alia. Increasing number of MIS-C cases in our emergency room has escalated the need for a case-oriented clinical approach for pediatricians to deal with MIS-C cases in a stepwise, self-acceleratory manner with algorithm for management. Professor Sana Abdurrahman, Professor of Pediatric and Shams University, kindly inform us about Pediatric Hospital and Shams University protocol for dealing with MIS-C cases.
It's my honor and pleasure to share with you this nice webinar, and I'm honored by the presence of Mr. President of Ain Shams University, Mr. Ashraf Omar, the Dean of Faculty of Medicine, the smart leader of the department, Dr. Mustafa Al-Hudhud, and the dynamo of the team of the COVID team, Dr. Iman Fouda, who had kindly invited me to share in this prestigious work. And she has been leading and orchestrating a symphony to deal with this catastrophic pandemic. We all know that there is a problem, but there are so many questions that are unanswered. Who's going to get it? Why? And what will happen? And where is that going to be, time frame? But at least we know now how to deal with it. Next slide, please. When I was asked with the team, we were collaborating together to work on, to work on an algorithm for this syndrome, for this issue. We started reviewing literature and see what others had done so that we can do the best we can, something to deal with the problem. And as you can see from the published papers, circulation, meaning something with the blood, and then the Journal of Pediatrics, and then the Gastroenterology, and finally the New England Journal of Medicine. Looking at the circulation, that their problem started there, and that was actually reflecting the cases in Europe, in France and Switzerland. And the problem there, they reported the data from March 22nd to April 30th. They had only 35 cases. All of them had received IVIG. 1/3 of the patients had received the steroids. What was the mortality rate? 0. Nobody had died. Then April, in the Journal of Pediatrics, this was a center in New York City, in Brooklyn, from April 17th to May 30th. They reported 33 children, 100% were on IVIG, 80% were on aspirin, and 70% were on steroids. Then in gastroenterology, that was a center in Columbia, from April 18th to May 22nd, they reported 44 patients, 95% were on steroids, 80% were on IVIG. The biggest study that was published in New England Journal of Medicine, and my colleagues had referred to, it actually included 26 states, cases of 186. Only 4 patients had died, and 3 of them, they had other comorbid conditions. All of them were on ECMO, so they had really a different catastrophic end. 77% of patients were on IVIG, around 50% were on steroids, and 30%, third of them were on anti-cytokines, whether anti-IL-6 or IL-1 receptor antibodies. Based on that, we said, okay, how are we going to deal with our patients? Are we going to follow this? Is there a certain protocol that we can deal with or not? Let's look at the next slide, please. Based on the seriousness of the problem and how much we can allocate the resources, and why this had been nicely explained by Dr. Hosni with the impaired immunity, and when Dr. Alia Otbi had just asked it, is there a genetic predisposition? Yes, there is an HLA haplotype specific to MERS-CoV viruses, not for the current COVID-2, but they are expecting the same abnormality in the 3 types of the HLA they found, that they will find a different presentation of the virus to the immune cells. They are specifically related to the COVID viruses. The immune evasion of the COVID virus, as well as the high viral load, those are the 3 most important factors that will predict that the course will be more or less severe. Starting from production of cytokines, activation of coagulation pathway, activation of, or hyperactivation, let's say, of macrophages and monocytes, plus what we call immune exhaustion or immune overstimulation or immune cell pyroptosis. Pyroptosis meaning disruption of the cell membrane and release of all the chemicals in the circulation. Overproduction, that will end up in overproduction of cytokines and chemokines, and hyperinflammatory state, and the multi-organ failure. Before the multi-organ failure, there might be some sort of coagulopathy or DIC. There will be a lot of cytokine storm that everybody had referred to, and there will be also tissue damage. And up till now, we don't know whether the virus is cytopathic itself. Is the virus still there? And although most of the MESI cases, they appear around 25, the median time in the New England Journal of Medicine said around 25 days after getting the virus for those who are infected. Is the virus still active? Is there a cytopathic effect of the virus? Is the virus, like HIV virus, still in the lymphocytes? Yes, still, there are so many studies on. Next slide, please. Those were the available protocols that we reviewed. We reviewed more than that, and all of them were kind of complicated. And we wanted what we call like the neonates, the first golden hours in the emergency room, are they really important? How can we guide the residents or whoever is in the emergency department to deal with the patient in a nice way? So we came up with all together as a group with the rationale behind this protocol. Next, please. Next slide. We put first the management based on a risk criteria. We had a combination of the WHO and CDC and our own vision and the presentation of the cases. We said that fever, we're not going to stay 3 days with the fever. 1 day fever is enough. 38 degrees Celsius is enough for 24 hours or more. Plus, is it one clinical symptom or two? Again, if it's a severe affection, enough, go with one. A patient presenting with shock, it's just one symptom, one clinical symptom affection, or two, maybe mucous membrane, conjunctivitis, lymphadenopathy, whatever you find. A positive history or previous exposure to COVID-19. Within how many weeks? Within 2 weeks or within 4 weeks? We extended this to 4 weeks. The COVID-19 exposure can be in the contact or in the patient himself or a patient in quarantine. And that guided us to tell the resident, those are the criteria that you have to consider and work up your mind as well. Let's look at the next slide, please. Based on the clinical picture, we said there are risk criteria. A patient at mild risk, a patient at moderate risk, or a patient at severe risk. We don't want to give IVIG, for example, for urinary tract infection or otitis media presenting with fever and patient is sick. This might be a mild risk. If the fever is kind of not reaching exactly 38 degrees, less than 3 days, and there are 2 symptoms, but the patient is not sick. This is a category that I will tell you what to do for those patients. Those patients that you're going to follow up, don't leave them alone because they can assume a severe track, because most of the patients of the MESI, more than 60%, ended up in ICU. That means they will assume a severe diagnosis right from the beginning or a severe risk criteria. If the patient is in a moderate risk group, that means patient, he looks to you like an ill patient with a fever more than or equal 3 days plus 2 of the symptoms of the inclusion criteria. A severe risk patient is the toxic, very toxic patient, patient in shock, patient in cardiac dysfunction, as Dr. Alia had pointed out. This is the severe risk. Those are the 3 categories of classification based on the clinical presentation of the patient that you have accordingly, whether to do $1 million workup or to do a limited workup or to follow up or to admit to ICU. Next slide, please. The workup in the first category, you have to do a CBC, a SID rate, a basic metabolic profile, including electrolytes, liver function and kidney function, BNP, CRP, and EKG, yes or no. If you find them within normal limits, within not excessively increased numbers, and we had put a criteria, what is the cut-off value, not a CRP of 3, a CRP of 6 is not going to be valid for me. At least we put the criteria for that in a nice table. Above 10 will be considered. Less than that, yes, CRP can increase with any infection. So there are certain criteria that you do this. If the patient in the first category had normal labs, you're going to discharge him. But with a follow-up, if he keeps the fever or he develops more symptoms, more organ affection, then he will come to the emergency room. This is the easiest way for follow-up within 24 to 48 hours. If the patient is a moderate risk, then you're going to add more labs, a CBC, a SID rate, a basic metabolic profile, CRP, BNP. Add, please, inflammatory markers. Look at the ferritin, look at LDH, look at the lactate, fibrinogen, look at the coagulation status, PT, PTT, D-dimer. And in all the moderate and severe cases, we send the PCR and serology. Are they going to help us in the diagnosis if they come negative? No. If they are positive, they are in support. You can do, of course, the AKG and echo, blood culture, urine culture, and it depends on the scenario. You can do up to abdominal CT because the abdomen is like in the gastroenterology part, they had biliary sludge, they had the bowel wall edema, and they were all part of the GI manifestations of the COVID. CTs, as you can see. In the high risk group, the same labs will be added, and this patient, please, rapid shock management and ICU admission, IV fluids, and as Dr. Hanan will explain later, sometimes those patients are refractory to fluids, so a fine assessment should be done. Next, please. Management principles that we thought of. I will leave this question for you. You want to start IVIG first or steroids first? To tell you the truth, it's a hard question to answer, even from the studies. But we decided that IVIG and steroids are the two cornerstones of the treatment. They are not only the only cornerstones. There are other important treatment parameters that you should follow. But the IVIG, which is the polyclonal IgG, should be given in a dose of 2 grams per kg with a cap, a max. You cannot give IVIG, it's expensive medication. We put a cap, like a chubby child, a cap of 160. Is it 1 dose or 2 doses? Again, it's left to the clinical judgment. If the fever subsides and you see that the patient had started high dose steroids and you want to manage your budget well, maybe you will need a second dose or you might not. But a second dose usually is needed in a Kawasaki-like picture with a persistent fever or symptoms. Those are the guidelines for a second dose. Then how many grams are you going to give the patient? 1 gram or 2 grams? It's again up to your budget. Certain literature says 2 grams per kg per day. So most of them, they agree on 1 per kg per dose or per day with a cap or a max of 100 grams. It's an expensive medication all over the world. The second line, or actually equally important, like the first line, is the steroids. We decided to stick to methylprednisolone. There are so many types, depending on your center, wherever you want to go. We decided with methylprednisolone. If it's a patient in a mild or moderate risk, you might consider 2 milligrams per kg per day in 2 divided doses. A severe one, definitely you will go, we advise going with the pulse therapy, which is 30 milligrams per kg per day, a max of 1 gram per day, and usually it's given for 3 days, followed by 2, and followed by a gradual taper for over how long? Over a week to 2 weeks. Choice of the steroids is left to you, left to the center, but this is the protocol at Ain Shams University. How about aspirin, acetyl salicylic acid? Yes, it has a role in a classic Kawasaki disease, provided that this simply is a Kawasaki disease like picture like Dr. Ali had just mentioned with a positive PCR. In this case scenario, you're going to use the full dose acetyl salicylic acid 30 to 50 milligrams per kg per day divided in 3 doses, and then you switch, try to decrease to 3 to 5 after 48 hours. We are saying this aggressively. Definitely those guys will be on a proton pump inhibitors and others, as we're going to explain in the next slide, please. Anticoagulants, we all agree, everybody agrees on low molecular weight heparin, but what is the dose? Is it the VTE prophylaxis or the therapeutic dose? And to moderate and severe cases, we decided and we agreed on giving on the prophylaxis dose, which is, as you can see, if the child is less than 2 months of age or above 2 months, either 0.75 milligram per kg, Q12 hours, or 0.5 milligram per kg. The therapeutic dose, of course, the patient is not going to, is not recommended unless the patient is presenting with something else. So again, there are no hard rules. All behind this, you have to have a clinical sense and a clinical judgment, but those are the guidelines or the recommendations. How about anti-inflammatories? Yes, we can use them. You can use anti-IL-6 receptor antagonist, anti-IL-1 receptor antagonist. After you do the level, how high the level is, we settle this. At least for IL-6, it has to be above 3 times normal, and the dose is well known for that. For how long, how many doses, it's left again to the clinical scenario. You need the dose, 2, you're going to continue depending on how severe the condition is. The choice between IL-1 or IL-6, again, it's different between studies. Some they like very much IL-1, others IL-6, depending on availability, depending on the budget, depending on the patient, and depending on the opinion of the consultants. Please don't forget other measures. Other measures will include antipyretics, will include PPIs, because bleeding here is a critical issue. Fibrinogen is needed. You need to judge the PT-PTT, need to be a fine balance. Platelet count need to be watched closely. And based on the fine tuning, then we keep proceeding further till the patient safely is discharged from the hospital. Next, thank you very much for your attendance.
Thank you, Professor Sana. Now comes the difficult part. A big percentage of our MESI cases presented in a critical condition really. We need to know from Professor Hanan Ibrahim, the head of Pediatric ICU, Pediatric Hospital and Shams University, what's our protocol in Pediatric ICU for the management of such cases and what is their outcome? Professor Hanan Ibrahim.
Thanks, Professor Iman. Let me tell you that in the very beginning, everybody kept telling us it's an adult disease. Pediatricians have no right to be worried, but it came. And thanks God, when it came, we were ready. Thanks to our frontliners, our residents, our assistant lecturers, our dear colleagues and the professors, the administration team, Professor Mustafa Al-Hodod, every single person in the pediatric department participate in the success during this era. Even we opened the new pediatric intensive care unit. It was about 8 beds, and now we extended beyond this to 12 beds. And till 1 hour ago, we served about 50 cases inside this pediatric critical care unit. Next. Next, please. Okay. What are the characteristics of pediatric patients admitted in the pediatric intensive care unit? We have the era of COVID-19 patients and the era of severe MESI cases. During the era of COVID-19 patients, mostly the patients admitted due to COVID pneumonia with respiratory failure, severe dehydration with GIT manifestations, disturbed level of consciousness with or without convulsions, and cytokine storm with DKA. While during the era of severe MESI, the fixed indication of ICU admission was shock. This type of shock was mainly septic shock, viral septic shock, mostly with cardiogenic element. In some cases with also hypovolemic element, and this is the difficult part in the management of these cases. Cardiac injury, different types of cardiac injuries, always there. With or without other organ injury, like AKI, acute kidney injury, CNS affection, hematologic affection, hepatic affection. Next. Next. Okay. Pediatric intensive care management of MESI. Here I will concentrate on MESI management severe shock cases as mentioned by Professor Dr. Sana. Usually, among these cases, we follow the regulations or the protocol of sepsis campaign, which is updated in 2020. We started with fluid resuscitation, but here we cannot adopt the generous fluid resuscitative method. Why? Because cardiac affection is anticipated among those patients. So we only give one bolus, 20 ml per kg, to be repeated once or not to be repeated. We have to be cautious about the heart among those patients. Then the vasopressors and the inotropics. We fixedly give norepinephrine and epinephrine, not dopamine and dopamine. They are much more arrhythmogenic for such patients. If milrinone is available, almost all our cases received milrinone for cardiac support without a loading dose. We needed low or moderate dose of epinephrine and norepinephrine among our patients. Just 2 patients needed high dose of epinephrine and norepinephrine. All our cases received intravenous immunoglobulins on 2 grams. No cases needed to repeat the dose. Steroids were given first at the low dose, then after adopting the protocol, we give the pulsed steroid dose as mentioned by Professor Dr. Sana. Prophylactic dose of low molecular weight heparin almost given in all patients. Empiric antibiotics, we adopted the protocol of vancomycin, ceftriaxone. Vancomycin is fixed because the septic shock syndrome is a differential diagnosis in such cases, so we have to give vancomycin, except if there is any need to withhold any drug with the renal affection. We need to do renal adjustment dose, or the patient is allergic to such medications. Respiratory support starting from non-invasive ventilation, high beat ventilation, high frequency ventilation. Prone positioning, we can do prone positioning, or we did prone positioning to almost most of the cases needed ventilation, even the non-invasive cases. How many patients needed invasive mechanical ventilation? 60 patients out of 42 patients till the presentation prepared. 2 patients needed high frequency ventilation. Next. What is the outcome among our patients? Non-survivors, 11 cases, 7 COVID-19 cases, 4 MIS-C cases. However, I can consider the real mortality of COVID-19 related cases are only 4 patients. Patients without any comorbidities, with immune encephalitis and septic shock, especially in that baby 37 days old. Other comorbidities participating in the cause of this among those patients, I cannot tell which of which, but mostly they died out of their comorbidities, like patients with TB, enteritis, TB, pneumonia, 1 patient with polyarthritis nodosa, 2 patients with leukemia. Next. Okay. Away from the non-survivors, we have a lot of superheroes, actually, like this little 5-year-old girl. This girl was previously normal with no history of chronic illness. She presented with fever, rash, gastrointestinal manifestation. This is followed rapidly by tachycardia, tachypnea, and shock state. This girl admitted in the ICU in a bad shape. Next. The initial lab were bad, actually, with thrombocytopenia, significant thrombocytopenia, impaired liver enzymes, impaired kidney function, very high CRP, high D-dimer, even a high interleukin 6. Next. So by definition, this patient suffered from multi-organ failure. She has heart failure because the echo showed significant myocardial dysfunction, respiratory failure as she passed into acute lung injury, ARDS, and even ventilated on high frequency ventilation, AKI, acute kidney injury, hematologic affection in the form of significant thrombocytopenia, and even gut failure with elevated amylases and lipase. Next. This was the X-ray on admission. She was on low flow nasal cannula. Chest X-ray was okay, but the patient rapidly developed ARDS and shifted the girl to high frequency ventilation. During this period, we give the patient, as per protocol, all necessary medications, IVIG on 2 gram per kg, pulsed steroids, low molecular weight heparin, prophylactic antibiotics, and anti-shock medications. Next. The patient condition gradually improved with elevation of the platelet count after IVIG and steroids, with gradual weaning from mechanical ventilation until extubation after 5 days. And thanks God, this girl discharged without significant morbidity. Inside the ICU, we are very optimistic about cases of MIS-C, severe cases of MIS-C. And we believe that if the patient has no significant comorbidity, whatever the severity of MIS-C, if we give the patient all the necessary medications as per protocol, most probably he will be a good responser. Next. Okay. Pediatric Department of Ain Shams University Hospital would like to thank the whole administration team actually, who helped us a lot to maintain an excellent service during the critical time. And I have to announce that this is our first session, but we promise that it will be followed by coming waves as needed. We aim to provide our experience and any update of our knowledge. And we aim also to represent an interesting cases that we faced in the last period. And I hope to be with happy ending. Next. Before telling thank you to our team in Pediatric Department, our Dean Professor Ashraf Omar, the President of the University, Professor Miteni, Professor Mustafa Hudhud, Professor Mona Gandouri, and all the panelists and all our colleagues today. I also would like to thank our residents, frontliners, for their great effort during this era. And before stopping the screen share, I want to thank the company who sponsored this event, Nestle Health Science. It's a company concerned about nutritional therapy. She helped us a lot in many aspects, and she helped us today to sponsor this meeting. Thanks again.
Professor Hanan, we have some questions for the panelists. We can start, please.
We have some questions. I think we have a lot of questions for Professor Ilham Hosni. I think. Professor Ilham, I think your talk was very challenging for many. Let me start. Someone asking about maybe lymphopenia. I am searching for.
Okay, I can start, Hanan. I have a question for Professor Mustafa. If you, okay.
There is one question for Dr. Ilham. If you let
okay.
me.
Okay.
Based on your presentation, Professor Ilham, is the empirical use of steroid might interfere with the process of natural healing?
No, that's not true. Actually, corticosteroids are life-saving in cases of MESI. The problem with MESI is not viral infection today. It's a post-inflammatory syndrome. It usually starts after infection for by weeks. Could be up to 2 weeks after the infection, or 4 weeks, as Professor said. So now our problem mainly is with the cytokine storm, is with the adaptive immune system going crazy. So what corticosteroids here are life-saving. We cannot ignore them at all. And they will not cause harm, but they will save the life of the patient.
Okay, thanks, Professor Ilham.
I want to add something. Even dexamethasone in the COVID infection itself, a trial was done on the duration of admission and the mortality rate. That was in Italy, and using a low dose of dexamethasone for 5 days had decreased the duration of the illness and had helped early discharge of patients, even with the acute viral infection.
Okay. Another question for Professor Ilham. I don't know if it is a statement or question. MESI can happen during convalescent stage of disease, although there is a memory cell. Is this a question?
If there is a memory cell, the problem would have been solved. Actually, those patients do not develop immunologic memory well after the exposure to the virus. And that's why they proceed to severe illness, including the MESI. Conduction of immunologic memory needs and duration of the infection and of the inflammatory response. actually we don't have enough memory. A recent article was published this month in the New England Journal of Medicine that says that mild infection do not provide prolonged memory or antibody response to the virus, but it actually needs a more severe infection to provide this prolonged body response.
Professor Iman, you have questions for?
Yes, I have a question for Professor Mustafa about the GI manifestations of COVID. They are asking about, we are in the summer seasons and most of the children have gastroenteritis nowadays. And all parents are afraid if this is just gastroenteritis, non-specific, or this is related to COVID. This is the question by many of our audience, actually, and many of the parents. So can you help us, Professor Mustafa?
Okay, thank you. This is a very important question. And because we are in the time of gastroenteritis summer season, it's very difficult to differentiate. However, in persons presenting with early manifestations of COVID, it's very difficult to differentiate because it's not severe presentation like in the late MESC pattern. But what is clear in the presentation of COVID is the severe abdominal pain that is associated with vomiting or diarrhea. So if you have this severe agonizing abdominal pain, which we usually not see in cases with gastroenteritis, this is in favor to think in possibility of early COVID. Sometimes vomiting is severe, not responding even to injectable forms of antiemetics, and this may take you toward this area. Again, these days we see Coxsackie, Herbangina, and hand, foot, and mouth disease. And if you found these symptoms in association with the diarrheal illness, you are now with something else than COVID disorder.
دكتور مصطفى، ممكن ازود حاجه على كلام حضرتك؟ بتهيألي ان كل العيانين الميسي في البرزنتيشن اللي اتقالت كانت 100% ليمفوبينيك وبتبقى باينه جدا، فاعتقد ان هم عندهم جاستروانترايتس حتى لو عندهم ليمفوبينيا مش هتبقى جامده زي العيانين بتوع الميسي والسي ار بي العالي.
دكتور مصطفى؟ دكتورة إيمان، أنا عندي سؤال للأستاذة الدكتورة علياء أقوله؟
أيوه اتفضلي.
في سؤال لحضرتك يا دكتورة علياء. Shall we include an echo screening for the children come with high inflammatory markers?
Yes, please. Because for the first impression or by auscultation, you will only find tachycardia. But the echo reveals findings that you cannot anticipate except if you know the disease. يعني احنا دلوقتي عارفين الديزيز, and that is why we are anticipating that in the patients we find pericardial effusion, we find valve involvement, and this valve affection is not that severe to cause a murmur. يعني احنا we find valvulitis, and in the affection of the ejection fraction, يعني الميوكارديال function تقل بس العيان not in frank failure. يعني مش لازم العيان يجي بفرانك هارت فيلير، بس انا لو ريحته واديت له تريتمنت he will not progress. الا بقى لان لو سبته he might progress. So please do an echo to all these patients. احنا at first الحقيقه انا دايما معلش انا بشكر برضو تيم الكارديولوجي. هو لما في حالات الكوفيد في الاول how did we know that we were having cardiac cases? They heard كانت مروه سمعت pericardial rub وبيستخدموا الايكو معاهم، فبيستخدموه يشوفوا العيانين، اكتشفوا surprisingly ان في cardiac affection بلس بقى تروبونين كمان لما بنستخدمه بيقول لنا. ف if you please please do an echo. Thank you for this nice question.
Professor Hanan, I have a question for Professor Yasmin Gamal. They are asking about who is taking nasopharyngeal swabs in hospitals.
Dr. Iman, thank you for the question. Nasopharyngeal swabs are taken by all nurses. All nurses were trained by infection control teams. At first there were specific nurses ان هم ياخدوا هذه السوابس، وبعد كده احنا دربنا كل الناس بحيث ان كله يقدر يكفر الهوسبيتال 24/7. طبعا في special techniques وفي special infection control procedures بتتاخد علشان ناخد السوابز من النيرسز. يعني عندنا one specified nurse في كل وورد او في كل فلور عندنا في الهوسبيتال.
بمناسبة السؤال ده يا دكتورة ياسمين، في سؤال شبهه كده بيسأل how much it was difficult to take a swab from children. They struggle, they are not obedient. لقيتوا مشكلة في أخدان السوابس؟
هي طبعا it's uncomfortable أساسا for an adult before a child. بس يعني بتتاخد هي سريعة. احنا التريننج والناس بقوا الحقيقة more experience ان هي تتاخد سريعة. والكوفيد بيشنتس احنا عندنا بارت منهم كان تقريبا 50% كانوا ICU patients، فما كانش فيها مشكله ان احنا ناخد السوابس. بس الاطفال ما بيبقوش cooperative قوي الحقيقه طبعا. بس we try as much as we can.
الرعاية طبعا مسطحين. ماشي.
Professor Hanan, I have a question for Professor Sana. They are asking about the inflammatory markers cut levels for diagnosis. As you told, CRP, ferritin, LDH, and D-dimer. Can we help us to put some numbers to help the doctors in diagnosing when we consider this is high inflammatory markers, because all of these markers are increased with any types of inflammation?
I'm glad you asked this question, but it is actually in the paper, but we say that CRP at least should be 10 and above. Fibrinogen should be more than 400. Lactate should be more than 2.2. Albumin less than 2.5. ALT more than 100. Or I will be conservative in that, depending on the situation as well. Creat should be more than 1 milligram. Troponin 0.04. Ferritin should be more than 500. But if you tell me 500, or if it is 450, sometimes you have, as I said, to work with two together. One is very high and one is borderline, but those are what we said, guiding guidelines. D-dimer should be more than 1,000, 0.1, like double the normal, as Dr. Fuda had mentioned. Platelets less than 100,000. And we said that absolute lymphocytic count, we really had a struggle with that. Should it be 1,000 or 2,000? But we decided that for children, we should go with a cutoff value of 2,000 to say that those patients are lymphopenic. Hemoglobin should be around 9 grams. So I hope that can answer the question.
Thank you, Professor Sana. I have one question for Professor Alia. Should we include troponin as a routine lab in the classic COVID case, or preserve it only for messy cases?
يعني احنا if we can do it for the COVID, this would be very nice, but I think it is mandatory in the messy. يعني I know it is not included for COVID ومش موجودة في الجايدلاينز انها تبقى من الروتين، بس أنا من الناس اللي أنا I would like to do it because we have seen actually cases of cardiac affection in the COVID cases.
The question for Professor Hanan, you have experience in using Actemra in ICU for your patients?
We use the Actemra in a single case. Even before the era of Messi, the case was presented with cytokine storm. Before the era of Messi, before the name Messi, this case has very high interleukin 6 and has multi-organ affection, pancreatitis, carditis, pneumonia, and we succeeded to pass with this patient. Only single case.
Okay, maybe last question about lymphopenia, if it's present in all cases of COVID or no. Actually, in 80 to 85% of cases of COVID, we got lymphopenia. However, actually, we encounter some cases which have no lymphopenia, but in the majority of cases, it should be present. Maybe this is the end of questions. Professor Mona Ganzouri.
By the end, I would like to thank so much all the participants in this webinar. The professors have given us very nice talks, concise and up to the point. All talks give us how to achieve clinical diagnosis and management in different presentations of the disease. I enjoyed every minute of this talks الصراحة. Especially دكتورة إلهام التوك بتاعت حضرتك ازاي انت شرحتي ازاي الاميونولوجيكال اسبيكتس حصلت، لان دي كانت بيج بالنسبه لي شويه. Thank again for Dr. Mustafa and Dr. Yasmin and our brave residents and assistant lecturers for their support in this crisis. Finally, I would like to thank Dr. Meteni and Dr. Ashraf Omar for joining us in spite of their very busy schedule. And I hope we stand strong in front of this aggressive crisis. Lastly, I would like to say happy Eid and كل سنة وانتم طيبين. كنت ليه كومنت بس دكتورة علياء بالنسبة ان هو الكواساكي and ميسي are the same or not. It is a variant، يعني الميسي ده it is a variant، هم بيخفوا بنفس التريتمنت. It should be considered a variant of a Kawasaki.
هو actually يعني هي مش هنقدر نقولها، يعني هو الكواساكي نفسه حتى دلوقتي مش معروف السبب بتاعه. يعني هل يا ترى هو فايرال برضو شبه كده؟ because الكواساكي
ما هي بوست فيروس، ما احنا مش عارفين الفيروس اللي بيعمله.
ما احنا بنتكلم ده الكواساكي، فاحنا actually don't know is it or not because we have never seen such a similar case. يعني احنا ما شفناش حاجه تشبه حاجه زي كده لما في الديليت سيكوال بتاعها. فانا actually I don't think because sometimes I think ان التريجر ان ده كان عيانين هيجي لهم كواساكي. الاول كان عندي impression دول عيانين هيجي لهم كواساكي and it was triggered by this virus.
الحاجه الثانيه
this was my impression. وبعدين بعد كده هو كنت فاكراه كده كمان ليه؟ علشان خاطر العيانين الدايابيتكس اللي هم بيجي لهم دايابيتس وقت بالسارس كوفي
بعد الكوفيد.
لانه هم زي ما يكون هم عندهم predisposition وهو بين البريدisposition دي. So I think دي هتحتاج discussion. أنا at least I'm not sure 100%. وفي الليترشر أنا ما شفتهاش مكتوبة 100% which is which. إن هي لحد دلوقتي they are debating about it. بس مثلا اللي أنا عايزة أقوله إحنا يعني أنا مش بحب أقول hard and fast rule عن حاجة وبنطلق العنان لمخنا إنه يفكر. معلش دكتور مصطفى هجيب سيرتك بقى. السؤال القصه اللي ما بيني وبين دكتور مصطفى فاكره يا دكتوره منى لما كان بيسالني على ستامي وكان قال 30 و40، قلت له ايه 30 و40 اللي انت بتقولها ده؟ ما كنتش فاهمه ايه ستامي اللي بيسال فيهم. ستامي ده استي سيجمنت اليفيتد مايوكاردال انفاركشن.
ايوه فاكره
فانا ما تخيلتش ان هو بيسالني على ستامي بتاعت الادلتس. فهو دكتور مصطفى بيقول لي يعني هو العيانين بتوع ممكن يجي لهم ستامي دول اللي هم بتوع الكوفيد دول يجي لهم ستامي ولا لا؟ هو ترومبو امبوليزم على فكره منشند اكتر في الكوفيد اكتر ما هم منشد في الميسين. يعني احنا ما شفناش ترومبو امبوليزم في الميسين. ممكن هيبان بعد كده، ما حدش يجي مثلا كمان كام يوم يقول لي حصل ترومبوز وانت قلتي لا. ما انا مش عارفه تنبأ بيحصل ايه. ده عمال بيعمل حاجات عجيبه وعكس بعضها. يعني هو عمال يخالف نفسه طول الوقت يعني. المهم دكتور مصطفى بيقول لي ايه؟ بيقول لي ممكن ده يحصل in the process of كواساكي عند حد كبير ومش حد كبير. قلت له احنا علشان احنا we are scientific people، عشان هو بني ادم scientific وانا scientific، احنا ايه اللي يمنع ان الكواساكي يجي لحد كبير؟ كواساكي لايك. انا بتكلم على الميسي. ده كان حديث ما بيني وما بينه في نص شهر يونيو. بعد كده ظهرت اللي احنا كنا بنقوله وموافقين عليه كده، هو حديث ودي كده علمي بس ان هو الحالات بانت بعد كده adults with ميسي اللي هي كواساكي لايك.
ليا برضه كومنت الدكتوره ايمان والدكتور حنان. انتوا حطيتوا في البروتوكول ان هو البالسس مثال بريدنيزولون على 30 مللي جرام ولا ما حطيتوش؟
حطيناه طبعا.
ده اساسي، ده اساسي
طبعا.
اصل انا شايفه ان هم في حالات تيجي بشوك هو ده مع الاي في اي جي هو اللي بينقذهم. يعني ما نستناش خالص، يعني ايميديتلي نعمله.
هو حتى سي سي جي بيبلغوني الاستاذ الدكتور هشام عوض معانا. انا مش عارفه هو ليه مش ظاهر، مش بيتكلم معانا.
هو دكتور هشام قال
اهلا وسهلا، اهلا بيكم جميعا. سامعين صوتي؟
دكتور هشام
سامعينك يا هشام.
اهلا وسهلا، كل سنه وانتم طيبين. انا ليا سؤال نفسي،
عاوزين نشوفك.
مش عارف ليه مش طالع.
عاوزين نشوف دكتور هشام.
انا ليا سؤال ليكم كلكم، بما ان
احنا مش سامعين دكتور هشام.
الصوت راح يا هشام.
لا حد عمل ميوت
دخل بانلست. هشام دخل بانلست دلوقتي. شغل المايك بتاعك يا هشام، والفيديو هتبقى مع الناس واضح جدا.
طيب
دكتور هشام
هو ممكن يسألنا السؤال او
افتح الفيديو والصوت يا هشام.
خلاص يعني ايوه بدأ اهو. لا ايوه تمام.
انتوا سامعيني كده؟
ايوه
شايفين.
طيب انا ليا سؤال ليكم جميعا. بما ان الانتراكشن ما بين اللوكوسايت والاندوثيليوم is very aggressive في المرضين دول، والبوسيبيليتي بتاعت الثرومبو امبوليك والكواجولوباسي والفايبرينوجين العالي والاي اس ار العاليه، كل دي ماركر اوف اندوثيليال انجري. ليه ما نفكر الاي في اي جي دواء؟ يعني احنا لما بتكلم في 80,000 الى 100,000 جنيه بير بيشنت، يا رب نقدر نوفره لكلهم. ليه ما نجربش البنتوكسيفيلين اللي هو ترينتال، اللي هو انا بتكلم في كوست اوف تريتمنت تقريبا 100 جنيه بير بيشنت، والسايد افكتس بتاعته مينيمال، بيضيع لي الانتراكشن او بيقلل الانتراكشن ما بين اللوكوسايت والاندوثيليوم، وليه بوتنت انتي انترلوكين 1 افكت. بيستخدم في البريفرال فاسكولار ديزيز، بيقلل الاسكيميا، بيستخدم في السبسس سيندروم اللي فيها بوتنت intravascular affection والبوسيبيليتي بتاعت الدي اي سي. بيستخدم، جربناه في النيونيت في حالات فور بريفنشن اوف الكواجولوباسي الشديده في النيونيتال سيبسس، وجاب اكسلنت ريزلت. وبتكلم في كوست اوف تريتمنت nothing to compare. بما ان الاي في اي جي بلا جدال بيجيب نتيجه، ليه ما نوجدوش كالترناتيف لو انا ما عنديش الاي في اي جي اديشنال للريجيمنت بتاعي، اللي انا ازود الترنتال لغايه ما اعرف اجيب له الاي في اي جي، او لو ما عرفتش اقارن الليمب اللي خد الترنتال بالليمب اللي ما خدش الترنتال ونشوف فيه افكت ولا ملوش افكت. الدواء ده مش اكسبنسيف، سايد افكتس مينيمال، فيري بوتنت افكت كانتي انفلاماتوري.
انا ما سمعتش عن الترايل ليه كانتي انفلاماتوري. يعني الجاكستات
يا هشام شفناك اهو،
كاينيز شغال كويس، التي ان اف
ومش حاسس ان احنا شايفينه
شغال كويس. المونوكلونال اي جي جي ليها فايده تانية، هي اتس ا جود نيوتراليزنج انتي بودي، هتبقى هي نفسها هتشتغل ليها انتي فايرال افكت. فهل هو انت بتتكلم على الفاسكولار بروبلم؟ طب ما انت اوريدي اديت انتي كواجولانتس، فانت وير از ذا بروبلم؟
اديت انتي كواجولانت، لكن I'm not preventing اللوكوسايت endothelium interaction. This leukocyte endothelial interaction هي مش بس علشان كانتي كواجولانت، الثرومبوزس اللي ممكن يحصل والفايبرينوجين اللي عالي والبلمونري هي ليه بيحصل البلمونري هايبرتنشن؟ ما البلمونري هايبرتنشن ده فايبرين ديبوزيشن. ليه الفيري اجريسيف سيتوكاين ستورم؟ هو في سيتوكاين ستورم من غير ليكوسايت اندوثيليال انتراكشن والانفولفمنت بتاعت الادهيزن والانتجرينز وكل الحاجات دي الشيرد ما بين الليكوسايت والاندوثيليوم.
في سيتوكاين ستورم without this adhesion. انت خلي بالك المشكله بتاعت الكوفيد زي ما الدكتوره الهام قالت، هي مشكله innate اكتر ما هي adaptive immune system. الانيت immune system اللي هم مين؟ الناتشورال كيلر والماكروفاجز والكلام ده كله، دولا يا فندم دولا. المشكله الثانيه التي اس ام ام اللي هو ترانس ممبرين سيرين، اللي هي الادهيجن بارت ابيثيليوم واندوثيليوم من اول سكه الاميون سيستم. عشان كده لما حد من الحاضرين كان بيسال ليه ما فيش اميون ميموري، لان اساسا الاميون سيستم واز نوت تريجرد. وانا بقول لك ان ريسنتلي قال لك ان في اتش ال اي تايبنج هو مسؤول عن البرزنتيشن بتاعه الانتيجين للتي سيل، ده هو المشكله بتاعتك. يعني هي من اول سكه الاميون سيلز، من قبل ما تخش على بقيته خالص هو خربان، هو اوفر ويلمد، وبيسموها حتى ايه اميون اكزوشن، اوفر ستيميوليشن بيها من اول ايه التي ال ارز والدامبس، من اول خالص الانيت اميون سيلز. فاهم قصدي؟ مش كده يا دكتوره
صح،
الهام؟
بس هو الميكانيزم بتاع الاورجان فيلير اللي بتحصل
انا
يعني
كنت ميكانيزم
غالبيته
اوردر فيلير 4. الميكانيزم
افندم.
اوردر فيلير 4، واحده منهم دي اي سي، واحده
ما
منهم
هو حاجه اساسي فيها اسكيميا اللي بتحصل في الاورجنز، اسكيميا في المايكارديوم، اسكيميا في البرين، اسكيميا كل one of the major mechanism of الهيستوباثولوجي اللي اتعملت للمرضى اللي ماتوا من الكوفيد في ايطاليا ورت هم اللي كانوا ورا الاستخدام الانتي كواجولانت. بما انه ده الميجر كوز بتاعت المورتاليتي، يبقى لازم احط في دماغي لوكوسايت اندوثيليال انتراكشن اكستريملي بوتنت.
انا ما اعرفش الترنتال
يمكن
استخدم ولا لا، بس نقدر نبص عليه، اقدر ابص
يمكن
هو
الايام
حتى لو ما استخدمش.
تثبت ان هو ممكن يبقى adjuvant in some treatment.
ايوه انا
ده
مش
مش
بقول
هقدر استخدمه لوحده، لان النظريه بتاعت الايرلي جولدن اورز بتاعتنا اللي فيها المين ديرينجمنتس محتاجه برضو IVIG، فيمكن اقدر استخدمه
انا
كادجوفنت.
مش بقول ان انا هستخدمه بدل الIVIG خالص فور ذا تايم بينج. ما اقدرش ان انا احط على
بياخد
جنب.
كام يوم على ما يشتغل يا هشام؟
انا قصدي هو بيشتغل very rapidly الترنتال بيشتغل اللي هو البنتوكسيفيلين. انا بقول ان if ever انا ما عنديش الافيلبل للعيان اللي انا اديله الIVIG، ليه ما زودوش كادجوفنت لماي ارمامنتيريوم العلاجي لغايه اما اقدر اجيب الIVIG؟
دكتور هشام، عاوز اقول لحضرتك بس ان احنا لو اتاخرنا على العيان ده 48 hours ممكن يضيع منا. يعني هم بيجوا فعلا.
انا مش بقول ان انا هتاخر
حتى كنا
intention.
بنبعت الناس تجيب IVIG.
هو يقصد adjuvant يا منى، يقصد adjuvant.
انا مش بقول ان انا عن intentionally I am withholding.
بس هو
انا بقول اللي انا استخدمه لغايه ما يبقى الIVIG available. احنا للعلم احنا في الشهر اللي فات ده صارفين ب900,000 جنيه IVIG، واحنا كل الفلوس اللي عندنا استنزفت. انا بسعى بشده ان احنا نوفر IVIG بكثره، ولكن انا لازم احسس الجونيورز بتوعي ان there is something else to be added اللي اقدر اعملها. a safe drug. This is a safe drug, a relatively cheap drug. أنا بتكلم على مئات الجنيهات بدل 80 إلى 100,000 جنيه تكلفة العيان الواحد. لو عرف أوفرها يا ريت، لكن حتى في أمريكا بيقول لك if available. طب if not available يبقى
هو اللي حصل يا جماعة الفترة اللي فاتت، معلش عشان خاطر الكلام بيقوله دكتور هشام. احنا إيمان لو تفتكري كان في عيانين دخلوا بميسي وما عرفناش نديلهم IVIG. فاكره السنه كان ادينا لهم سوليوم، اخذوا سوليوميدرول واخذوا فول دوز سوليوميدرول.
ريسبوندد الحقيقه للسوليوميدرول.
ايوه وهم كانوا عيانين كاردياك كمان يعني، والكاردياك سيمتومز بتاعتهم راحت بعديها بشويه. فهو البروبلم اللي دكتور هشام بيقولها ان احنا فعلا بنتعرض لمواقف ان احنا ما يبقاش عندنا IVIG، مش ان احنا مش عاوزين.
انا عاوزه اقول لك ان انا كان عندي حاله فيري كريتيكال واخدت حتى اكتمرا، اديتها سنجل دوز اوف IVIG، السكند دوز كده ده اللي حصل لها سيفير رياكشن، ما قدرناش ندي، بس ادينا سوليوميدرول على 30 مللي جرام والبنت باست كويس قوي. فممكن نبتدي سنجل دوز لو في العيانين اللي هم اوفر ويت مع سوليوميدرول.
صح ممكن.
انا بس ليا وجهه نظر.
انا عارفه ان ما اعرفش في التشيلدرن، انا عارفه ادلت ستاديز في ايطاليا كان ادجوفنت زي ما الدكتوره الهام قالت، بس انا ما اعرفش was it tried in children ولا لا لسه.
لا هي ما اقصدش، بس لا انا سؤالي للدكتور هشام بقى في حته الترنتال ده، ان هو اللي بيقولوا يعني I think ان الدور بتاعه اكتر في الاكيوت كوفيد ستيت، اللي هي الحته اللي انت you are preventing thromboembolic manifestation of fibrin deposition endothelial activation and so on. But do you mean again انها it might be effective in the MIS-C؟
ده اللي انا في ذهني.
يعني
انا بقول انه من اول
بحيث انك انت دلوقتي you are suggesting ان احنا we give it a trial في الميسي كمان بصرف النظر عن كوفيد، لان كل يعني احنا مالناش دعوه بثرومبوزس دلوقتي، لان اكشولي الثرومبوزس في الميسي قليله.
انا مش بتكلم على ثرومبوز، انا بتكلم على انتر اكشن ما بين لوكوسايت واندوثيليوم، بينتج منها حاجات كتير خالص، من ضمنها الفايبرينوجين اللي طلع في السماء واللي احنا بنشوفه ده اللوكوسايت اندوثيليوم انتر اكشن.
I think احنا لو احنا حاجه زي كده محتاجه انها to be discussed، نشوف الداتا بتاعتها and to be added as an adjuvant كترايل للعيانين اللي ما فهمش عندناش IVIG ليهم.
ده فكري بالظبط، اللي انا I'm not going to withhold it، ولكن لو الظروف كانت خارج ايدي اللي انا مش عارف اوفر للعيان I think to give him the best chance I can add this effective drug with minimal side effects. السايد effects بتاعته قليله جدا جدا، approved دلوقتي في اليوز في النيونيتال سيبسيس، يعني اللي هي الفيري vulnerable الفيري البيشنت اللي هو اي سايد افكت للدرج هيبقى بيقضي عليه في النيونيت وفي البريماتيور سيبسيس approved to be used.
دكتور هشام، دكتوره منى، في حاجه مهمه يا جماعه. اولا ديسكشن عظيمه للغايه، لكن ناقص حته عشان احنا بيسمعنا شباب اطباء دلوقتي معانا. لما تيجي فكره زي دي للدكتور هشام، الخطوات كالاتي: الاستاذ الدكتور هشام هيكتب بروبوزل اوف ريسيرش ويحطها اد اون ثيرابي، ويقول لنا انه الاي في اي جي لوحده عمل اوت كم كذا، او مع البنتوكسيفيلين كانت النتيجه كذا، ولو كان الافكت significant and marvelous difference between the two groups you can shift للبنتوكسيفيلين لوحده as an isolated therapy in these conditions. أنا قصدي أقول إنه كمية الريسيرش، أكبر بلد عاملة ريسيرش دلوقتي من أكبر البلاد في العالم، الاستاديز متسجلة باسم مصر. فما عندناش مشاكل أبدا، بالعكس أنا شايف دكتور هشام إذا سمحت لي
فكرة هايلة والله يا دكتور.
لازم بروبوزل من حضرتك ومجموعة من اسم الأطفال فورا، والبروبوزل ده يتقدم ونبقى بنشتغل في النور، وتتسجل كلينيكال ترايل على clinicaltrial.gov، ولما يثبت ان هي فعاله 100%، لان احنا الحقيقه عدينا مرحله we are in a hot situation we can use anything. فبالتالي انا عندي الاي في اي جي، حضرتك بتقول كلام جميل جدا جدا جدا، انا مش لاقيه، طب ولو مش قادر الاقيه اعمل ايه؟ يبقى بسرعه، والريسيرش زي ده مش هياخد اكتر من اسبوعين ل3 اسابيع، لان الحالات موجوده دلوقتي، وبالتالي you can use it as an add-on therapy to IVIG to see، وتعمل بروبوزل سريع ويتقدم ويشتغل، ولو النتائج بتاعته طلعت حلوه هيبقى innovative idea 100% ان شاء الله.
انا ده كان فكري يا دكتور مصطفى بالظبط كده، انه يتعمل ريسيرش فيه، علشان احنا اولى الناس اللي احنا تو سيف اور ريسورس. احنا وي ار بور كونتري، اما بور كونتري
بور يا دكتور هشام، مش بور بس.
ما انا عارف يا ار بور كونتري، اما تقولي لي بور كونتري ونستنفذ كل مدخراتنا بتاعت الادويه في الاي في اي جي، ماشي، we have to save the children، ولكن لو عرفنا نعمل حاجه ارخص يا ريت نقدر نوصل لكده.
دكتوره منى ممكن اعمل كومنت؟
اتفضلي دكتوره زينب.
انا يعني الحقيقه اقتراح الدكتور هشام انا ادمايرت، لان فعلا بيبقى فيه اندوثيليال اكتيفيشن، وانا شايفه ان this is a good suggestion for research، بايلوت ستادي نعرف بيها اذا كان ليه افكت ولا لا. انا عايزه ادخل منها بقى على الماكروفاج اكتيفيشن، واسال الدكتوره سناء على الماكروفاج activation in these patients. ازاي اعرف what is the marker that you rely upon to differentiate between just a MIS-C case and a case with mass? In such a case, يعني do you give send immune, you immunosuppress the patient to that extent even if it's having a virus still there. دكتوره سناء مش عارفه لسه معانا.
هتشخصي الماك في الاول، يعني هو العيان في اول برزنتيشن اول يوم جاي لك انت شخصتيه، هو الفكره انت هتشخصي الماك اكتر للي هو البيشنت اللي هو not responding او getting worse، او السيتوكاين ليفلز بقى عالي في السما. اذا كنت هتشخصي سكندري HLH او ماكروفاج اكتيفيشن، في الحاله دي انت مضطريه في ستاديز مستمره في استخدام الانتي ال6 for 6 days، يعني ايماجين والانتي ال1 1. وفي الحاله دي كمان الاي انتي ال 1 الاناكيندرا بيستخدموه اكتر حتى من التوسيليزوماب او الاكتمرا. هي دي الكويشن بتاع اللي هم not responding patients to the initial management اللي احنا قلنا عليه اللي هو الابروفد مانجمنت للميسي. لكن من الاول هل هو جاي لي وهو اوريدي في ماكروفاج اكتيفيشن وانا ما لحقتش اعالجه؟ يعني مش هشخصها في الاول، انا هشخصها ميسي في الاول واعالج واشوف تاني يوم العيان بيرسبوند ولا لا.
بعد اذنك يا دكتوره سناء بس عاوزه ازود حاجه ان العيانين responding dramatically the second day. the second day والاوتكم فعلا marvelous. يعني من ساعه ما احنا ابتدينا نستخدم الكومباينيشن اوف اي في اي جي with 2 grams 2 grams مع هاي دوز اوف سوليميدرول، النتائج بتهيألي يا دكتوره حنان كلها 100% خرجوا صح؟ هو يمكن اللي اتدهوروا اللي هم كانوا اتاخرنا عليهم شويه.
واللي عندهم كوموربيديتي حضرتك
بيقول لنا متاخر،
واللي عندهم كوموربيديتي وفي الكوفيد 19
ما هو ده سؤالي يا دكتوره حنان. سؤالي كان اساسا عشان اللي عندهم كوموربيديتيز والدنيا ملخبطه خالص، فكان which ماركر اللي اقدر بيه اقول ده دخل في ماس، مع ان الماركرز بتاعت الماس معظمها اوريدي افكتد في
دول تقريبا. هي ما فيش شارب لاين يا زينب في الرقم بالذات عشان اقول لك، لكن هو ماركت انكريز يعني هو
بس which ماركر يعني
الحاجه الوحيده ان انا هقول لك حاجه، اي فيرال انفكشن هيعلي لك الدي دايمر، واي انفكشن جاستروانترايتس وهتعلي السي ار بي. هم انهي ليفلز احنا حطينا اللي هي البوردر لاين ليفلز للميسي، ما عملناش بوردر لاين ليفلز للماك او السكندري اتش ال اتش.
لكن soluble CD25 ما يخدمنيش هنا؟
ما ده هيتعمل.
لو عملت soluble CD25 هل يفرق لي؟
هيفرق هيطلع لك الاتش ال اتش
كلينيكال جراوند
يعني مش عالي. ما فيش حاجه بتقول ان هو عالي في الميسي.
ما فيش لا في الميسي
ما اتعملش زينب ما شفناش يا زينب في الببلش داتا ان CD25 عالي من الميسي شخصيا. يعني دي ما بانتش في الموجود لحد دلوقتي في الافيلبل.
وفي تاني اعتقد ال 163 هم اثنين بس مش فاكره 163 ولا 163 as far as I remember يعني
163 ال 163 احنا عملنا عليه ريسيرش عندنا
163 والسي دي هم دول مش هيبقوا في الميسي في الاول، الا بقى لو الميسي زي ما قالوا حضراتكم ان هو جاي من الاول كان متساب، ومعظم الناس مش هيبقوا متسابين، معظمهم هيبقوا جايين. يعني في حاله كانت موجوده ابتدوا لها النواب على اظن 2 او 10 مللي جرامز، تاني يوم دي سويتشد على 30 لو حضراتكم فاكرين واحنا بنشوف الحالات. لما فعلا زي ما الدكتوره منى هانم قالت، اول ما الهاي دوز البلس ستيرويدز بلس هنفترض انه حتى ما خدش الاي في اي جي، البلس ستيرويدز حقيقي بتعمل افكت كويس.
ده صحيح، في عيانين استجابوا للسوليوميدرول لوحده حصل.
ايوه فعلا
حتى الدوز لو ما عندناش اي في اي جي جزء كبير جرعه كبيره يا دكتور هشام، لو استخدمنا حتى 1 جرام بير كي جي هي احسن من اللي حطيت مثلا 100 جرام بس مثلا يعني والوزن واحد
عنده. يا دكتوره سناء كنت عايزه اقولها جدا عشان بيرفع بلاد بريشر.
عشان كده هي البروفيلاكتيك ميجرز بقى الثانيه، كل السبورتيف ميجر سواء بتدي بي بي اي في عيانه حصل لها بليدنج، هل هي جي اي ميسي جي اي ولا بليدنج من التريتمنت؟ انت دخلتي في فاين لاين. عشان كده قلنا ايه، والدكتوره حنان معانا اتكلمنا قلنا انت هتدي ثيرابيوتيك دوز ولا بروفيلاكتيك، انت حتى ما انتش عارفه اذا كان العيان اساسا عنده ايه. فالعمليه برضو يعني عايزه فيري فاين ادجستمنت.
لا يا دكتوره سناء هم معظم اللي اخذوا بروفيلاكتيك دوز وخرجوا عليها بعد كده حتى اتحسنوا جدا وما حصلش لمده شهر دلوقتي اي سايد افكتس،
مفيش اي بليدنج تندنسي ولا حاجه.
ساعات سبكوتينيس حاجات بسيطه يعني، انا ما شفتش غير حاجات كده. مش عارفه حنان ايه الاخبار يا حنان؟
حالات الروماتولوجي
شفتي بليدنج؟
في بدايات الحالات لما كنا بندي ثيرابيوتيك دوز شفنا
الثيرابيوتيك هي
اللي بروفيلاكتيك
لكن البروفيلاكتيك عشان كده احنا عملنا شيفت على البروفيلاكتيك ايفن قبل البروتوكولات ما تقول بروفيلاكتيك.
ايوه
ان احنا عرفنا ان اولادنا احنا يمكن لان في الرعايه الدواء بيتاخد صح، بيتاخد بالظبط، بيتاخد في مواعيده، بنبقى حريصين انه ما يبقاش حضرتك عارفين الهيبرين والكليكسان والحاجات دي ليها تخزين معين فبيتاخد بطريقه معينه. فاحنا اكتشفنا ان الثيرابيوتيك دوز تعمل بليدنج في الاطفال دول، فعملنا شيفت على البروفيلاكتيك.
والبروتوكولات العالميه كلها بتستخدم البروفيلاكتيك دوز unless ان العيان عنده coagulation بروبلم او هو بيكون بروثرومبوتيك يحتاج بعد كده
نقدر بقى نشكر يا ايمان CCG ونقفل ولا لسه ولا؟
انا بس عاوزه اشكرك يا ايمان انت وحنان جدا على البريباريشن بتاع this meeting. It's really covered all the aspects وانا enjoyed every minute حتى الدسكشن اللي دلوقتي. Thank you so much.
رائع عشان كده رائعين.
لا ونشكر ايمان كمان على مجهودها الحقيقه اللي نشتف تقعد بتلم يعني واكتيفيتيز. والله نشكر الجميع وميرسي حنان وميرسي يا سناء. ميرسي يا دكتوره الهام على المعلومات الرائعه والله.
قيمه جدا يا دكتوره الهام والله.
والله يا دكتور هشام سعادتك نورت الكلام الجميل اللي انت يؤدت. هو مش سامعني، مش عارفه هشام سامعنا ولا لا.
هو دكتور هشام قافل المايك بتاعه.
يعني انا مبسوطه جدا من الدسكشن والافكار والاسئله اللي الناس الاتنديز حاطينها. الحقيقه اسئله في منتهى الذكاء لو بصيتوا في الكويستشنز اند انسرز جميله جدا.
الحمد لله.
قبل ما نقفل نشكر CCG هم اللي نظموا الايفنت ده.
ونشكر طبعا
معانا ونشكر نسلا هيلث ساينس هم السبونسر
واستاذ حسين من CCG.
بالظبط كده، وان شاء الله الى ايفنتات قادمه باذن الله ان شاء الله.
شكرا جزيلا يا جماعه والله.
ميرسي يا دكتور مصطفى.
شرفنا بحضراتكم جميعا.
ميرسي يا دكتوره منى.
ميرسي دكتوره علياء، ده حضرتك يعني التوكس بتاعتك.
ربنا يكرمنا وتتكرر هذه النشاطات العلميه.
كل سنه وانتم طيبين. كل سنه وانتم طيبين.
تصبحوا على خير وكل سنه وانتم طيبين.
انتم من اهل. تصبحوا على خير.